Thank you very much for the privilege of presenting at this inaugural ROHHAD International Consortium Rare Disease Day Symposium. The title of my presentation is What and Why Everyone Needs to Know About ROHHAD. Full disclosure, we share a tireless dedication to the amazing children and young adults worldwide affected by ROHHAD. And we have received generous past research support from ROHHAD Fight Inc. and the ROHHAD Association. ROHHAD and CCHS have been linked from first reports in 1965 for ROHHAD and 1970 for CCHS. ROHHAD is the acronym for Rapid Onset Obesity with Hypothalamic Dysfunction, Hypoventilation, and Autonomic Dysregulation. CCHS is the acronym for Congenital Central Hypoventilation Syndrome. On the right-hand portion of the slide, you see the face sheets for these first two initial publications, and you'll immediately note that both have the term Ondine's curse in their title. The painting on the left is of Ondine. She was a sea nymph who fell in love with a mortal, and the mortal was unfaithful. So the king of the sea nymphs put a curse on him that unless he remembered to perform all bodily functions, they wouldn't occur. Suffice it to say that patients with ROHHAD and CCHS are definitely not cursed. They don't forget to breathe. It's part of their innate clinical condition. And Ondine didn't do the cursing. So we preferred to avoid this literary misnomer, but do recognize the association in those first initial case reports. The hallmark of ROHHAD in CCHS is hypoventilation with altered respiratory control. Patients have shallow breathing, asleep and awake. They have progressive hypercarbia and hypoxemia, but a failure to increase breathing or awaken, as shown on this physiologic tracing on the slide. Awake, the patients have no sense of shortness of breath, but they have the ability to consciously alter the rate and depth of breathing. This table in the far left column indicates characteristics of autonomic nervous system dysregulation. And in the far three right columns, the percent of a specific cohort who have any of these characteristics. So for example, ophthalmologic manifestations reported in 87% of the initial ROHHAD cohort, 86% of the CCHS cohort, and 2% of the controls. And in decreasing frequency, you'll note ophthalmologic manifestations, thermal dysregulation, gastrointestinal dysmotility, altered sweating, ice cold hands and feet, extreme bradycardia, and syncopal episodes. Also note that Hirschsprung disease has not been reported in any patients with ROHHAD, but occurs in about 30% of patients with CCHS. Neural crest tumors have been reported in about 40% of patients with ROHHAD, and only in a subset of patients who have CCHS, specifically those who have a certain kind of genetic mutation. FOX2B, the paired-like homeobox gene, is the disease-defining gene for CCHS. And you see on this slide a FOX2B expressing neuron. The regions of expression of FOX2B in the central and peripheral nervous system and in the enteric nervous system are shown on the left-hand portion of the slide and actually match up rather well with the clinical phenotype for CCHS. But the elusive etiology of ROHHAD, a multi-system disorder that requires multi-subspecialty care that may delay the diagnosis. You can see all of these detectives representing the different subspecialists who might see a child with ROHHAD. And the important issue with ROHHAD, one of the important issues, is that the ROHHAD phenotype is confounded because of the controller breathing deficit and the autonomic dysregulation, or translated more simply, because of less than fully intact responses to changes in oxygen and carbon dioxide, and less than automatic responses to the systems that should function automatically. The emergence of ROHHAD as we know it dates back to 1965 when the paper by Fishman et al. Was published, describing the initial case of what we now call ROHHAD. In 2000, Elliott Katz described a single case and summarized the prior 10 cases in the literature. In 2002, we met this adorable little boy named Scott, who introduced us to the clinical phenotype of ROHHAD. And then by 2007, we were able to offer the acronym ROHHAD to expedite the diagnosis and intervention, representing the typical order of clinical features of the phenotype. The RO stands for rapid onset obesity, a 20 to 30 pound gain over 3 to 12 months in a healthy child between 1.5 and 7 years of age. The first H stands for hypothalamic dysfunction, with features unfolding over time. The second H stands for hypoventilation, which is often preceded by obstructive sleep apnea. And the AD stands for autonomic dysregulation. This slide is a template for several subsequent slides. On the y-axis, where you see 1 through 15, each row indicates an individual child with ROHHAD in the original cohort, published by I.C. Ludlow in 2007. And on the x-axis is age in years. R and the oval red symbol indicate the timing of the rapid onset obesity. In this figure on the right, a traditional growth chart, and you can see in this child's growth proceeding fairly normally, and then all of a sudden this abrupt uptick, and then an even more steep trajectory, indicating the characteristic weight gain in a child with ROHHAD. This slide indicates the features of hypothalamic dysfunction on the left-hand column of the table and the percent of the initial ROHHAD cohort on the right-hand column. The important takeaway is that not all patients get every aspect of hypothalamic dysfunction, but over time, many of the patients have multiple features of hypothalamic dysfunction. Also of note, hyperprolactinemia is apparent from very early on in the phenotype unfolding. In the initial cohort, we identified 47% of the patients affected, but now, having been involved in the care on site as well as remotely of at least 150 children who meet criteria for ROHHAD, we're comfortable saying that 100% of patients with ROHHAD have an elevated prolactin. The hypoventilation is indicated in blue and with the oval symbol. It needs to be looked for because it evolves over time. This is a figure by Ilya Kaitin, recently published in the Journal of Clinical Sleep Medicine, and it's indicating the recorded spontaneous breathing in hours per day on the y-axis and the age of the child in years on the x-axis. And this is one child, very tightly chronicled and very pristinely managed. At onset, the child was breathing 24 hours per day spontaneously, awake and asleep. At the next evaluation, during sleep, the child required artificial ventilation with a mask and mechanical ventilator. By the next evaluation, the child required a tracheostomy and mechanical ventilation during all wakeful and sleep time. But with advancing age, the awake spontaneous breathing has improved, and at the last evaluation, the child was breathing spontaneously during all awake time. So what we describe as unfolding of the ROHHAD phenotype and then refolding as the child's breathing improves. This slide indicates the ventilatory responses to awake exogenous peripheral and central chemoreceptor challenges, in this case, hypoxic hypercapnia, 14% oxygen, 7% carbon dioxide. The patients with ROHHAD are shown with the cross symbol, and the control patients are shown with the dashed line. The upper figure is minute ventilation, and you can see that the control subjects have a very steep increase in minute ventilation during the 3 minutes of the challenge, with data shown as percent to baseline. The vertical line indicates the end of the 3-minute challenge and the onset of recovery, and sustained increase in breathing in both cohorts. This increase in minute ventilation is primarily due to an increase in tidal volume among the control subjects, again, shown here on this bottom figure. This slide is addressing the cardio and cerebrovascular responses to awake exogenous gas challenges, the same again as the prior slide, hypoxic hypercapnia. I draw your attention to this bottom figure, where on the y-axis, we're showing cerebral regional blood flow and oxygenation, as a percent of baseline. And what you can see is the control subjects in a self-protective mode increase their cerebral regional blood flow and oxygenation, in contrast to the patients with ROHHAD who don't provide an increase until after the challenge has ended. And even then, it's a rather subtle increase. So the diagnosis of hypoventilation may be difficult, but it's essential since it's life-threatening. The CA and the green ovals indicate the timing of cardiorespiratory arrest in the first 15 patients in the first description of ROHHAD as we know it. And then the X indicates the timing of a death. Subsequent to the 2007 publication, there were 2 additional deaths in this original cohort. So what causes the cardiorespiratory arrest and the mortality? Well, delayed identification of hypoventilation and consequently delayed introduction of mask ventilation for nighttime sleep. Also non-compliance with mask ventilation or refusal of a tracheostomy placement when the mask is inadequate. And also absent physiologic testing in varied activities of daily living to determine the need for awake artificial ventilation. Without optimized artificial ventilation and vigilant management, the child with ROHHAD is at risk for recurrent asphyxia and potentially death. This slide indicates the timing of the tumors of neural crest origin in the original cohort, shown with the orange ovals. These are typically ganglioneuromas or ganglioneuroblastomas, but rarely a neuroblastoma. They occur along the sympathetic chain or in the adrenal glands, and they're typically removed because otherwise they'll continue to grow in situ and interfere locally with normal function. So the next part of this presentation is addressing the quest for biomarkers in ROHHAD. Our aim is to provide early identification of new patients by having consistent biomarkers, to prompt intervention before respiratory failure, again, following these biomarkers, and to optimize long-term follow-up. But additionally, to prepare for therapeutic intervention trials. One promising biomarker is the weight gain trajectory, comparing a cohort of patients with ROHHAD versus a cohort of overweight and obese pediatric controls. There are 3 different ways of looking at slope. One is the traditional weight slope, how many kilograms gained over a certain period of time. One is a percentile slope, the percentile on the growth chart for which that weight occurs. And one is the modified percentile slope. So if the weight is over 95th percentile, a modified way of reporting that percentile. Well, in the ROC curve on the left-hand portion of the slide, showing sensitivity on the y-axis and specificity on the x-axis, we're comparing these 3 slope measures. And you can see that the percentile slope, shown in red, had a lower performance than the weight and modified percentile slopes, shown in blue and yellow, which had similar performance. And in one of the platform presentations later today, you'll be hearing more about this particular project. Another potential biomarker is the heart rate, shown here on the y-axis, with age shown on the x-axis, with advancing age in one child with ROHHAD who is very tightly chronicled from the timing of onset of the initial symptoms. And you can see in this red rectangle, there's elevated heart rate during the first year from the time of the ROHHAD symptom onset. But then the heart rate declines with advancing age. And by 5.7 years, it was near consistently less than 90th percentile for age in this gray tone region. Another potential biomarker is the pupillary light response latency, or the time from light stimulus to the onset of the pupillary constriction. Latency, expressed in seconds, is shown on the y-axis on this slide, and age on the x-axis. The data for the patients with ROHHAD is shown with a blue line, for the normal weight controls shown with the red line, and for the overweight and obese controls shown with the green line. What these data indicate is that the latency trajectory differed between all 3 of these groups in the peak ROHHAD onset window, the 1.5 to 7 years of age. Peripheral skin temperature is yet another potential biomarker. On these two graphs indicating data for the right hand in the top figure and the right foot in the bottom figure, with temperature on the y-axis and age on the x-axis, again from Dr. Caton's very careful and thoughtful publication. The circles indicate the temperature at the tip of the finger in the top graph and the toe in the bottom graph. And note that this temperature is often equal to or colder than the ambient temperature shown with the asterisk. So the bigger biomarker vision in ROHHAD is to identify reliable biomarkers in hospital and to validate the technology in hospital for use in home. And then to replicate these biomarkers with wireless wearable devices in home, awake and asleep in the child's natural setting. Our main goal is to advance understanding of the ROHHAD etiology and to prepare for future intervention trials in this rare and very dispersed population that can't necessarily get to a center with expertise in ROHHAD. The physiologic devices that we call wireless wearables are shown on the right-hand portion of the slide. The Hexoskin shirt has inductance plethysmography bands at the level of the chest and abdomen, as well as integrated heart sensors, activity sensors, and of course the breathing sensors. And we can see the data either on a phone or on an iPad. The data from this are shown in this figure from a study in children with Rett syndrome. You see the number of events per hour on the y-axis, and then you see the data divided by wakefulness and sleep. The other wireless wearable device that our patients wear simultaneous to the Hexoskin, we've for now called the flow system. You can see it's very flexible, it's very soft. The child wears it on the forehead. It has photodiodes that allow us to measure cerebral regional blood flow and oxygenation, as well as the skin oxygenation, positionality, and accelerometry. Comparing this to the gold standard, in this bottom right-hand figure, we show cerebral oxygenation with the wireless wearable device, data shown in red, and the gold standard near-infrared spectroscopy shown in blue, and you see the remarkably tight association during an orthostatic challenge with head-up tilts. So what is the etiology of ROHHAD? Well, genetic investigation has been extensive, and including candidate gene testing, next-generation sequencing, and methylation-sensitive assays, exome and genome level sequencing, and to date, despite extensive efforts, no specific gene abnormality in ROHHAD. Ongoing investigation includes somatic mosaicism, intronic variants, epigenetic modification, and more. And considering the absence of expression of a gene that should be present during neural development, or aberrant re-expression of a gene that should have been silenced following normal development. Is ROHHAD an autoimmune paraneoplastic condition? Well, anti-hypothalamic and anti-pituitary antibodies have been described in one patient, but more specific autoantibodies have not been identified. The presence of oligoclonal bands in cerebrospinal fluid and immune cell infiltrates in brain, including hypothalamus and brainstem at autopsy, have been described in single patients. But removal of a neural crest tumor and or administration of immunosuppressive therapy has not consistently stopped, reversed, nor resulted in sustained improvement in the ROHHAD phenotype based on individual case reports. And later, another platform presentation, this by Dr. Benson, will be addressing new data in response to this question. So ROHHAD clinical management involves serial, comprehensive inpatient evaluations in centers with extensive experience in ROHHAD. These evaluations are based on the systems affected, including the endocrine system, respiratory and cardiac systems, the autonomic nervous system, evaluations in sleep and wakefulness in varied activities of daily living to get a full sense of what the child is doing physiologically when home or when at school. Also formal neurocognitive testing and education for the families and referring physicians, because this is an entire community of teamwork that's involved with the child and family at the core so that we can do everything to keep the child safe and minimize disease burden, but also educate in the process so the next child with ROHHAD can have an expedited diagnosis. And again, a goal to optimize neurocognitive outcome, because with intervention trials, we want the children to be able to have the best opportunities with any of the intervention trials. So artificial ventilation and objective monitoring are essential to optimize neurocognition in ROHHAD. And this young lady, shown here in a real trip to Paris in front of the Eiffel Tower, and shown here actually carrying her ventilator in this portable suitcase. Also oximetry and capnography to objectively document the success of the ventilator settings and used during wakefulness and sleep. This is disproportionately large, but it's still to emphasize the point of the need for objective monitoring. This slide addresses the neurocognitive indices in a cohort of patients with ROHHAD syndrome versus population means. These indices are shown in this far left column of the table and indicate that ROHHAD is distinguishable from population means on full-scale IQ measures. Also, ROHHAD patients in this cohort are above population means on reading and math, but below population means on visuographic and drawing skills. And what we've learned as we've grown this cohort of neurocognitive testing is that there seems to be a cognitive bifurcation. So there are two distinct subgroups likely related to cardiorespiratory arrest and or suboptimal management. And then there are the children who have had very early identification and very successful conservative ventilatory and endocrine management who are able to thrive and have test results as shown in this table. So it does take a village to identify the child with ROHHAD, to make sure that that child is cared for by all of the different specialists who are involved in that child's care, and to realize that any one of these pediatric specialists might be the first person to see the child. So the sleep medicine physician might need to recognize that the obstructive sleep apnea that's now resolved actually is just the antecedent to the central hypoventilation. The pulmonologist might see a child on a ventilator, but put together the backstory that there was a rapid weight gain involved. The oncologist might notice that the child presents with enuresis and an adrenal tumor, and on history obtains an abrupt weight gain. And the emergency physicians and the critical care specialists might see the child for the first time with a cardiorespiratory arrest. But what we're really counting on is that the general pediatrician is going to see that rapid weight gain and refer the child for more extensive endocrine and physiologic evaluation to determine if the child has ROHHAD. So with that, I thank all of you for listening to this presentation. I show you a picture of our hospital here in Chicago, just blocks from Lake Michigan. And this point actually goes directly to our laboratory on the 3rd floor of Ann and Robert H. Lurie Children's Hospital. At the bottom of the slide are the links to the International ROHHAD Registry at nih.gov and the International CCHS Registry. And I look forward to any questions you may have. And again, thank you for your attention.